everyone, and welcome to UT Southwestern Medical Center. My name is John Guerin. I'm the Communications Coordinator for the Department of Radiology. September is Prostate Cancer Awareness Month, so we're doing our part by having a discussion about PSA screening and prostate imaging, both of which pertain to diagnosis of prostate cancer. We're here with one of our UT Southwestern partners in patient care, Dr. Daniel Costa, a physician who specializes in radiology and in particular body magnetic resonance imaging, or MRI. Before we get started, I want to remind everyone to make sure that you ask your questions in the comments section on your Facebook feed, and be sure to like and share our chat. As I said, this is a very timely topic, and we want to make sure everyone gets a chance to watch it who needs to see it, and that we get some good traction with this video. So please remember that Dr. Costa cannot comment on individual cases due to patient privacy laws. Well, let's get started. First of all, Dr. Costa, we've received some questions in advance, and so I want to make sure and incorporate those into our chat. The number one question is, can you tell us something about prostate cancer? How common is prostate cancer?
Sure, John. Thanks for the invitation. It's a pleasure to be here. Good afternoon, everybody. Well, John, prostate cancer, other than skin cancer, is the most common prostate cancer in men. The American Cancer Society estimates that this year alone, approximately 150,000 men will have prostate cancer.
Wow.
And of those, around 30,000 will die from the disease. So these numbers show that it's definitely a very important topic in men's health. Just as a frame of comparison, breast cancer is estimated to have about 40,000 women dying of breast cancer in the same period. So, but prostate cancer is full of its own challenges. One of them is the fact that it's a mixed bag of bad and not so bad types of tumors. And it's usually a silent disease, which means that very rarely and usually only in advanced stages it will cause symptoms such as difficulty urinating. And that is one of the reasons why screening with PSA is an important topic.
Okay. Tell us what PSA stands for, what it is, and what we should understand about PSA.
Okay. So PSA is the abbreviation of prostate-specific antigen. It is a protein that, as the name implies, is produced by the prostate cells. And when we talk about PSA, what we're referring to is the amount of PSA in the blood that is measured with a simple blood exam. Until not too long ago, there was a cutoff of 4 as being to differentiate what is normal versus abnormal. So up to 4 would be considered normal, and 4 or greater would be considered abnormal. But as we learn more about PSA, we know that these numbers have to be seen within a context of the patient's age, of the size of the prostate, and also how these values change over time.
So what's considered normal? I mean, what would a normal PSA level be?
Again, this is an information that needs to be looked at within a context. So what is normal for a man may not be normal for another man. We know, for example, that men between 50 and 60 years old, a PSA of 2.5 may be much more concerning than a PSA of 4 for somebody who is 75 years old. So really important to look at those numbers within a broader context. And that's one of the challenges that people who want a simplistic answer to what PSA or how PSA can help me cannot get.
I see. Well, what are the recommendations for PSA screening? I know that they're very controversial and that they're confusing and that there have been a lot of changes to the recommendations over the years. Can you tell us what the current recommendations for PSA screening are?
Absolutely. So as you said, this is indeed a highly controversial topic. And the truth is that even among specialists, there is no consensus. So depending on where you look for this type of information, what is offered you varies a little bit. Now, one of the most commonly used guidelines, that's how we call these recommendations, is the one issued by the USPSTF, which stands for United States Preventive Services Task Force. And what they recommend is that in men between 55 and 69 years old, the decision to screen with PSA should be made on a case-by-case basis. And that's what we call shared decision making. So that means that you and your doctor should discuss the advantages and the disadvantages of screening with PSA before getting your PSA checked. Now, for men that are who are 70 years or older, the American Urological Association, the AUA, recommends screening in certain selected patient populations, particularly in healthier individuals who are expected to live a longer than average life.
So when Warren Buffett, the financier, received a diagnosis of prostate cancer, he was almost 80 years old, and he decided to forego treatment at that time. It's likely because prostate cancer is a slow-growing cancer, and if it's discovered in an adult man after the age of 75, the benefit of treatment probably far outweigh the risks associated with that treatment. Would you say that's the case?
That may be an oversimplification statement, but it is true that many of the prostate cancers are slow-growing tumors that will take years to cause problems. So depending on the type of cancer, this number of years to cause problems vary, and depending on how long you're expected to live, you may not live long enough to have those problems. So it is true that if you find a certain type of prostate cancer in a certain type of patient, it is not unreasonable. So it would be okay to have that patient undergo periodical reevaluations without necessarily having to treat that patient.
Well, speaking of risks and benefits, are there any problems or pitfalls with PSA screening?
Absolutely. So, as we said previously, PSA is produced not only by cancer cells, but also by the normal prostate cells. So for this reason, conditions other than cancer can be associated with an elevated PSA, such as, for example, what we call BPH, benign prostatic hypertrophy, which is a fancy name for the growth that some men experience in the prostate as they age. And the same thing with inflammation. So what that means is that you may have a high PSA without having cancer. On the other hand, some cancers do not produce PSA. So you can have the opposite of this, which is you may have cancer and have what we would still consider a normal PSA for your situation. So that is why PSA is not perfect, but it is one of the many pieces that you have to put in this intricate puzzle, and then and the diagnosis of prostate cancer ultimately will require a biopsy.
So you mentioned BPH. Do the symptoms of BPH are they similar to the symptoms of prostate cancer? And is that why it's important to have a screening procedure so that you can determine whether you have prostate cancer or BPH? So
early prostate cancer generally will be what we call asymptomatic. So it will be a silent disease. Advanced cases of cancer, in other words, when the cancer has grown quite a bit, just because of how large it gets, it may present as BPH does. So it is a common confusion that BPH and cancer are related, but they are not. So you may have a very large prostate because of BPH and have no cancer, and vice versa. You may have a very small prostate with no BPH and still have a very concerning cancer.
Well, we have a question here about biopsy. Can you tell us what a biopsy is, and in particular, what a biopsy for the prostate involves?
Sure, absolutely. So, as with any part of the body, the same concept applies. A biopsy is a procedure where we want to take small pieces from a certain area of the body. In this case, we're talking about the prostate, right? So what we do is we use a needle that collects a few small pieces of tissue. And then what we do is we send these pieces of tissue to a pathologist who will be able to look at these pieces with a microscope and determine whether or not there is cancer. And if there is cancer, they're going to tell us how aggressive that cancer is. Currently, it is the only way we can tell someone whether or not he has prostate cancer. So in other words, things like PSA and MRI can suggest that someone may have cancer, However, it is only by biopsy in the prostate that we'll be able to confirm that.
I see. And how can radiologists and MRI help someone who may have an elevated PSA to understand whether they have prostate cancer?
That's a very important question. So until not too long ago, these biopsies were performed using what we call a random or systematic approach. What that means is that we would take pieces from various areas of the prostate in an attempt to have a good representation of the whole gland and hopefully catch any possible cancer. This would be equivalent to, for example, a woman who has an abnormal mammogram be told by her gynecologist, let's have multiple biopsies from different areas of your breast and hope that one of our needle passes catch that cancer. That doesn't seem to make any sense. Now, more recently, fortunately, we learned that MRI can reliably detect areas suspicious for cancer. So systems were developed to leverage that ability to see suspicious areas with MRI and then let us perform what we call a targeted prostate biopsy. So that we direct the needle towards those regions that are suspicious. This is a superior biopsy technique because it detects more cancers, particularly the cancers that we want to detect, that we would not want to miss because they are more aggressive. Now, the MRI also can help a man with elevated PSA, even if the MRI doesn't show any suspicious areas, because in selected men, that can be evidence that you needed to avoid or postpone that unnecessary biopsy. So to summarize, the MRI can help you and your physician decide whether or not you need a biopsy, and if you do, we'll help you guide this biopsy by directing the needle to the areas that might have cancer.
Okay. Are all MRIs equal? If not, what should patients and referring physicians look for when deciding where to have their MRI performed?
Well, John, I wish it were a simpler answer, but the reality is that no, not all MRIs are the same. One of the challenges that we have is that the quality of the report of a MRI is highly dependent on the quality of the equipment that is used to generate those images, and also the experience of the radiologists involved with the interpretation of those images. So if you or someone you know need a prostate MRI, you should find a place that has what we call 3 Tesla scanners. These have stronger magnets that generate better image quality. Also, find a place that has high clinical volume and where we radiologists interact with urologists, pathologists, and oncologists to work closely and exchange information that will help us get a better understanding of each case, including your case.
Okay. If someone has just had an MRI of the prostate, what is the next step?
Well, if your MRI showed suspicious regions, then your physician may decide to do a target biopsy. If your MRI did not show any concerning area, then your physician may choose to postpone the biopsy, or depending on other things like PSA, family history, if you have family members who had prostate cancer and you're considered a person at higher than average risk, they may decide to do what we call the systematic biopsy that we discussed before, the one where you're taking pieces from various areas of the prostate.
I see. Well, I know that we're having some technical difficulties with our camera, but I want to keep pressing on because this is such an important topic, and we can easily convert this video to a podcast. So I just want to continue our conversation, Dr. Costa, because I think it's so important. You mentioned that there are bad cancers and not so bad cancers. Can you explain what you mean by that?
Yep, so that's one of the challenges of prostate cancer, right? It's a very common disease, but just as common, it's also a very heterogeneous disease. It's this very wide spectrum of aggressiveness, from tumors that will grow very slowly and never cause any problems to very aggressive, life-threatening forms of the disease. So this highlights the importance of not only detecting the disease, but also knowing which type of disease you're dealing with. This is again, the fancy term that we use is risk stratification. And while this is an area that we learn more about every day, currently the aggressiveness of cancer is mostly estimated by what we call Gleason score. Gleason score is a scoring system that pathologists use when they look at those pieces that we took during biopsies. When they look in the microscope, they will see how the cells look like and how they are arranged. And that gives us an indication of how bad that cancer is. So this is the cornerstone of the risk stratification in a man with diagnosed prostate cancer.
I see. Well, if I've already had a biopsy that has shown prostate cancer, do you need an MRI after that?
Well, although
What's the benefit of having an MRI after you've already established that you've got prostate cancer through a biopsy?
so currently, MRI would not necessarily be standard of care, and we're still learning a lot about this. Each case is a little bit different. However, having said that, most likely the MRI will provide some meaningful information for the management of your case. Again, it's a little bit of an oversimplification, but if someone who has prostate cancer is usually within one of two broad groups. One is the cancer that was found was not so bad, and you can be watched. If you fall in that category, which you call putting you under active surveillance, what we want to make sure is that what your biopsy showed is not the tip of an iceberg. In other words, that there is not a larger or more aggressive cancer that went undetected or poorly sampled during that biopsy because of the deficiencies of that conventional classic systematic biopsy system. Now, if you get an MRI, and if you're in that context and you get an MRI and the MRI doesn't show anything concerning, that might give you the reassurance that active surveillance is the right approach for you. Not only for your reassurance, but also your physician will be more comfortable keeping you on active surveillance.
So active surveillance is sometimes called watch and wait.
Watchful waiting is there are nuances to what watchful waiting would be versus active surveillance. It's a little bit more detailed than what we have the time to discuss, but active surveillance, watchful waiting may be just watching you, whereas active surveillance requires checking there is a structured regimen that you have to follow, things like checking your PSA every X months or repeating biopsy in certain circumstances. Watchful waiting is a little more liberal, and you're being truly watched more so than intervened upon. Now that is one of the broad categories. The other broad category is you have a cancer that it needs treatment. Now, if you are in that group, then the MRI can help you and your physician with information that will tell you how big your tumor is, where it is located, and whether or not it has spread beyond the prostate. This will help you decide what is the best treatment for you, and if the treatment is surgery, it may help your surgeon tailor the surgery so that the entire tumor is removed. In all contexts, MRI can provide some meaningful information that affects your management.
I see. Well, I think we're going to wrap up our conversation. As I mentioned, we were having some technical difficulties with our video, our video stream, but we'll be able to convert this to a conversation to a podcast, and we'll post that as well on our Facebook stream. So thank you so much, Dr. Costa, for being with us today. Did you have any final remarks that you wanted to make with regard to our topic?
Well, thank you, John, for moderating this conversation. It's been a pleasure. Thank you, Facebook users and those watching or listening this on demand. I hope you found this useful. And all these things that we talked about, PSA, early detection, screening, biopsy, these are complex topics that elicit a lot of questions. And it's definitely a group of things that motivate us to pursue what we call precision personalized medicine. And the only way you can achieve this is through engagement of the patients, their significant others, and a strong collaboration between different disciplines: urology, medical oncology, radiation oncology, pathology, and radiology. So I think that is critical for us to be successful, and I would encourage any of you with questions to, I would like to make ourselves available so that if you have any questions, please reach out to us. We'd be happy to try to clarify.
Well, thank you, Dr. Costa, and thanks to all of those who joined us today. Don't forget that this chat will be available here on Facebook. As I mentioned, we'll be converting it to a podcast, and you can also be able to listen to it on our YouTube channel later today, where we will continue to receive your questions after the chat is concluded. So if you need more information about scheduling or follow-up clinic visit on this topic, just let us know. You can always call us at 214-645-8300 to request an appointment. Again, that's 214-645-8300. Please share this chat with your friends and loved ones so that we can help spread the word about the importance of discussing PSA screening and prostate health with your doctor. It could save a life, and that life could be yours. Thank you very much.